mentioned that we hear people talking about a public health approach. And one of the reasons that the World Federation of Public Health Associations established the Global Charter for the Public Health and the way we frame things is to make sure that when people are talking about a public health approach, they do cover those three areas, the fundamental areas of protection, prevention and health promotion, but also those enablers that we talk about accurate information, capacity building, good governance and advocacy. These are all fundamental parts of a public health approach, and many times I see people using parts of those rather than a broader approach. So it is something that we do need to keep in mind. But I'd like to start with Peter. Peter, having watched and having listened to Manica just now, one of the things I think is most interesting to us is have you got insight into the real reasons for the lack of research and development up till now, and the lack of into antibiotics and antimicrobial resistance, and what do we need to do to overcome this problem?
Thank you very much for giving me the floor and having me. Manica and I are, of course, partners in crime or brothers in arms, because we have been, as WHO, closely involved in GARP. So we share his analysis that we do need to do more on R&D, because we have actually a relatively empty pipeline, and we have published last year a report as WHO where we looked at all the antibiotics that are in clinical development, and we also rated them looking at whether they are really innovative, whether they're likely to overcome resistance for the priority pathogens we have identified. And we are going to do an update of this analysis this year, and also try to move into the preclinical space. And in this process, both Manica and I, we have spoken a lot with the companies, and before we set GARP, we did actually an analysis to see, is this actually adding value? And we spoke with the big pharmaceutical companies who are still in antibiotic development and asked them, what do you think? And they said, yes, there are things that we are not going to do because it is just financially not interesting for us. It's not feasible. And that is what Manica said about the repurposing, looking into the old antibiotics. So industry said, yes, we do support actually this approach of setting up GARP, because you will focus on things that we are not going to do. And we also see that companies are coming to see GARP with projects they are not going to pursue because it's just economically not viable. And so I think that is one reason, and the other reason is that, I mean, many companies tried to develop new classes of antibiotics over many years, and if you speak with these people, they just met scientific challenges. It is, and you can see it in the attrition rates. It is an area which is more where you have actually less success than in some other areas of pharmaceutical development.
Thank you very much. I wonder if you mind passing the talking stick to Viviana. And Viviana, can you please just let us, the audience, know about South Centre? But also, I think, affordable access to new medicines is a fundamental problem, along with diagnostic tools and vaccines. Can you talk about how research and development models have an impact in this area?
Thank you, and thank you for having me here today. First, just to say, South Centre is an intergovernmental organization of developing countries, and we're very pleased to have Ghana counting as one of our members. So from our perspective, we're very, our vision in the area of innovation, as you just mentioned, is clearly linked together with access and, of course, with stewardship. So we think that efforts need to be made to think about the innovation ecosystem in a broader sense, and to really ensure that we are focusing on access issues as part of the solutions that we look forward to in R&D and innovation. And why? Well, clearly, if we see what are the global challenges, innovation is a top priority. We do have a very dry pipeline, as was mentioned before, both by Mark Sprenger as well as now by Manica. But we also need to make sure that innovations that come out will be available And that means that they have to reflect priorities and needs of a diversity of different patients around the world. And if we look at low and middle-income countries, the problem of access is significantly higher in some of these countries than the issue of innovations themselves. So even with older antibiotics, we could do a lot, as was mentioned by Manica, in repurposing older antibiotics, making sure, for example, that we have adequate pediatric forms. And there we also have to think about those types of players. Some of them might be, for example, manufacturers that would have capacity. There might not be patent barriers, but there is really no incentives for them as well to continue to produce these products or to adapt them, for example, in pediatric forms. So there's a number of target areas that we have to think about, not only about perhaps hitting the lower hanging fruits, but also long-term planning, but thinking about the ecosystem with the multiplicity of players. So in that sense, in focusing on the access issues, again, I would highlight that our vision is really to think about how do we implement what member states in the UN and all partners have agreed, which is in the UN High-Level Declaration on Antimicrobial Resistance. So I hope you're all familiar with this document already. If not, in 2016, the United Nations came up with an agreement among all countries that is now a UN resolution as a result of this political declaration. And on research and development, it clearly links it to access. It states that all research and development efforts should be needs-based. So we say public health first, the needs of patients first. Secondly, that it should be evidence-driven. This means that where are the priority areas? What are those gaps we need to fill? And if we look at current pipeline, as in the WHO analysis that was presented by Mark Springer this morning, it clearly shows that we are not necessarily hitting all the priority pathogens we need. And for example, an infection disease such as tuberculosis needs to continue to be a key focus within the MAR space. Now, the principles for R&D ensures that we should have access for all patients that we need, regardless of their capacity to pay. So this includes the principle of affordability that's included on this agreement, as well as effectiveness, efficiency, and that really means that we need to focus also on how do we create more collaboration in the innovation space. We know that there is perhaps a space for more pre-competitive collaboration even within industry players, but the role of governments can be really strong also in creating incentives to foster this collaboration. We need more clinical trial data information, for example, to be shared more widely so that we're not overlapping or wasting resources. And again, the dearth of focus at the early stage is really important. It's very sexy to hear about incentives for late-stage development and all kinds of these big initiatives, but at the same time, we really need to focus on how do we get the pre-research phase also moving on.
Thanks very much. I wonder if you can pass the microphone to Philip Howard and Philip, you're representing pharmacy internationally, and of course pharmacy is a key element of public health. And I think I'd like to mention the context. We've just listened to Viviana talking about good government stewardship, which we in the Global Charter talk in terms of good governance. Mark this morning was talking about the Sustainable Development Goals that are so fundamental to public health. But pharmacists are right at the forefront here, and so I'd like you just to outline for us how pharmacists can assist, not just in developing countries, but in low and middle income countries as well.
Yeah, thanks for the invite, and apologies for not being here from the start. Thank you, the French, traffic control. So you probably don't know the International Federation of Pharmacists, FIP. We are a global network that represents 140 national pharmacy organisations over 100 countries and represent 4 million pharmacists and pharmaceutical scientists. And they cover everything from early research through to formulation that we've sort of heard about already, the licensing elements of it, procurement, distribution, but also community pharmacies, hospital pharmacies, and everyone else sort of like that. Pharmacies are fairly essential in what sort of happens, because you can go to anywhere in the world and the first person that people go to see when they're ill is often a pharmacist. The reason is you don't need an appointment to go and see a pharmacist. And they're the ones who probably make that early decision whether you've got a fairly self-limiting sort of illness or whether you need to be referred on to a medical practitioner, or in some of the developing parts of the world, a nurse quite often will be the first person you end up sort of seeing. One of the bits that FIPs has been working on over the last sort of few years is really updating our statement on antimicrobial resistance to make it very clear what we expect from all pharmaceutical organisations. And one of the key bits on there is about following your local rules about dispensing and supply and all the legislation that goes with it. And ideally we'd like to see that sort of strengthened. And so through our 140 organisations, they've signed up to this. So even though we've heard some of the reports that Herman's maybe talking about a little later within Europe, over-the-counter antibiotic sales, certainly our member countries who are in there are really sort of fighting to try and do things about it. The other bit that pharmacists really essentially is safety netting. And so when patients are sent away with some symptomatic treatment, not using antibiotics, is actually that information if they become more sick, who to actually go and see someone fairly sort of promptly, or if they get an antibiotic from a doctor when we dispense it, then we can actually say to them, actually, if you do get worse, despite the antibiotic, you need to go back and see your practitioner. So that safety netting is really sort of quite important sort of on there. The other bits which are really important is from the public health point of view, is making sure patients take their medicines properly. We know there's an awful lot of poor adherence, especially with antibiotics. Estimated about 50% of courses are actually taken. There are big problems with eating leftover antibiotics and giving them to the rest of your family, not pets and so forth. And some of the bits that we're really trying to drive is a responsible return of unwanted antibiotics, but also supplying the right quantity of antibiotics to complete the course. We know that many countries supply complete packs because that's what the rules in their organisation talk about. We also have some directly observed therapy where pharmacists work with TB. Of course, many countries of the world that works particularly well. But more importantly is the evolving role in vaccination. We know in a lot of the work that people come in for antibiotics for upper respiratory tract infections. If we can try and get the pharmacist to vaccinate, especially with influenza, we can prevent some of those infections. And we've seen work from places like Ireland where they've actually increased by 18% high-risk patients of getting influenza by offering that sort of walk-in type of service. So we really need to be doing that. And then finally, it's all about the public awareness campaigns. We have greater footfall that comes into community pharmacies than goes into any GP practice or hospitals on a regular basis, and we end up having to do that. The hospital sector is really essential. Some of my research that I've done with part of ESCMID has shown that pharmacists are often the people who run hospital antimicrobial stewardship programs sort of out there, and they're essential for all those development of guidelines. But one of the bits, coming back to one of the early speakers, is about shortages. Yeah. Shortages are, I think, in areas of the world where we have relatively low levels of antimicrobial resistance, a bigger problem than pipeline antibiotics. And we've heard of the World Health Assembly, a paper put forward about medicine and vaccine sort of shortages coming on. But until we get real transparency of the API manufacturers and those who assemble the antibiotics, and we can actually say there is one API and there are 3 assemblers of the final sort of product, we will never be able to have a better way of almost controlling or predicting the shortages that we've seen on a daily basis, both in primary care and in hospital. So I think there's a lot of challenges, and pharmacy are at the very middle of everything that happens.
Thanks very much, and we'll go now to Gary. And Gary, you've listened to the other speakers. It's one of the great parts about being the fifth person. But you work in diagnostics in particular, and so we're quite keen to hear how you think what specifics the area of diagnostics what sort of innovation in rapid testing, what types of capabilities are needed. I believe these are your areas, and perhaps you could elaborate.
Sure. Well, thank you, Michael. Thank you, Bettina, for the invitation. Also, Marta, for the wonderful organization of this meeting. So I'm going to mention two types of innovations that are needed, and I'm going to mention them and come right back to them. The need to do rapid bacterial versus viral testing in primary care, and the need to do rapid identification and antibiotic susceptibility testing, primarily in acute care. But I'll come back in a moment because Bettina heard me speak at the AMR Industry Alliance event here in Geneva, I think it was back in January, and I made a comment to say that diagnostics are the Cinderella in this picture, because the stepchild, because we were not getting invited to the ball, that all the focus was on development of new antibiotics. No one was talking about the need for diagnostics, even though you can't practice effective antimicrobial stewardship without diagnostics. Well, the good news is Cinderella has an invitation to the ball. Diagnostics are on the agenda now. However, Cinderella is being told, first you have to build a carriage made of solid gold, and that'll cost you maybe $30 to $50 million. And then you have to get a dress for the ball, much more expensive than Meghan's dress for the royal wedding. That was £300,000. That's a fraction, at least 10 to 20 times more than that. And then when you show up at the castle gate won't open for you. The castle gate will be closed. Now, what do I mean by that? We don't really have any indication that these investments in new diagnostics are made, that they'll go into use. And perhaps the best indication of that is today, there are rapid tests available at very reasonable cost. When I say reasonable cost, if you go into Starbucks and you get the big coffee, I think it's called grande, whatever they call it, it'll cost you as much as this test. Today, you can do the rapid test at point of care for flu and RSV, common upper respiratory tract infections, so you can distinguish those as viral infections. There's only 2 countries in the world who are really using those tests at any scale. The United States and Japan do rapid flu testing. Flu immunization, by the way, which you mentioned, very few countries are more or less requiring meaning really strongly recommending that for everyone. Those are things that can be done today, but they're really not being done today, nor do you see a push for it being done today. I had the pleasure and opportunity to have very high-level meetings in the UK over the last several months, and I think they were fantastic, the most collaborative meetings I've ever seen across the public and private sector. They're moving in the direction of a pilot for rapid flu testing, and they're in such a lead on AMR, you would expect them to want us to continue to be in the forefront. And then antibiotic susceptibility testing. In hospitals, the evidence today shows that even when it's being done, it's not going back and changing the therapy. Now, what makes this so important? Now, let me come back to the 2 innovation areas, because we are investing to help, and other companies are investing, to do a rapid bacterial versus viral test at point of care, beyond just flu and RSV. And we're investing to make identification and susceptibility testing happen more quickly, because today is 2 to 3 days. What makes that so important? If you don't know precisely what's causing the infection, whether it's viral, bacterial, parasitic, or other causes, you don't know what treatment to prescribe. And more often what will happen if a patient presents at the emergency room with a high fever, a broad spectrum antibiotic will be diagnosed, and that was mentioned in the earlier presentations. What makes that so dangerous? It's not just the misuse contributing to resistance, is that a broad spectrum antibiotic more or less kills off all the bacteria in your microbiome. And if you have a resistant organism, it won't kill that off, that becomes dominant. And that's when the treatment actually becomes the greatest risk to the patient. You'll see a patient coming in with a high fever, ending up in the ICU in a life or death battle, because the treatment itself put them at greater risk. And there are technologies today that are available that can take a full day off of that testing. Very innovative technologies, again, not going into use. So I would say that as we invest as an industry in developing these new innovations, which will be typically $25 to $50 million of investment for a new diagnostic, it's going to be important to see also progress being made in the regulatory environment and the reimbursement environment, because the medical practice today is not commonly putting diagnostics into use in this manner. A few other things I'd like to mention on this. Infection prevention and control gets talked about. It's not on the agenda today, but it's extremely important, because keeping the existing diagnostics useful for as long as possible, and surgical site infections, urinary tract infections, central line infections, these are the areas, and other vascular access, because anytime you're invading the skin, penetrating the skin, often the organism is coming from the patient's own body, if it's happening in the hospital, or from another patient. These resistant organisms spread easily. And then the other key area that we're working on a number of other areas. We're working on data collaboration. By the way, these tests, point of care that are available today, are Wi-Fi enabled. So they can add to the surveillance as they go into greater use. We're also working with CDIP, if you're familiar with them, on providing extensive data that will bring their reporting much more up to date, and IHME to contribute data for the Global Burden of Disease report. Last thing I want to mention is the need to raise awareness. If there's one thing that's missing here relative to other major public health interventions, I think it's, frankly, the fear that existed. If you think about HIV, fear and massive death led to massive activism, which led to massive change. Ebola, which affected a much smaller number of people, also created massive fear. I'm not usually one calling for fear. It's not a positive emotion. But that doesn't exist. This is happening at a sort of one-by-one basis. As part of the work we're doing, we've come into contact with families who've lost their family members. There's a Rory Staunton Foundation. Their son, 11 years old, died from sepsis, which is closely related to this because it also relies on diagnosis. 11 years old, had a cut playing basketball in the schoolyard and died 4 days later because it wasn't properly diagnosed. He wasn't treated right away. Tatiana Vargas, a young woman who contracted MRSA while traveling on her holiday, on her honeymoon, nearly died from it. We need to get more of these patient stories out because that affects opinion as much as anything we can talk about technically. And because of that, we've also mobilized a campaign called Resistance Fighters to get those stories out and many others. And I can talk more about it, but I've taken enough time for now.
In fact, if you don't mind passing the microphone to Viviana, I'm going to come to her a moment just to ask her to respond to what you've said and apply how it applies in low and middle income countries, just for a few words on, if you'd like to, on what Gary has just said. And when you're talking about creating fear, we call it creating a sense of urgency. And one of the things that's very difficult, I think, in this area is creating that sense of urgency. It's the old boiling frog story, that when these things happen slowly, people don't notice. But Ebola, people seriously notice it, and I think that's a big public health challenge for all of us. Viviana, did you want to make a comment before I go to Manica?
Sure. Well, I would agree diagnostics is also a very essential intervention that needs to be made in this area. So we're looking at, we need new medicines, but as well, much more use of diagnostics, vaccines. So that's core also to prevent, as was mentioned. In the case of the low and middle income countries, diagnostics, in order to increase their use, they really need to be more cost effective in the sense that if you are going to promote in the public health system their use, we really need to bring prices down, so that's key. I think some of the partnerships that have been established in this, such as FIND, are really doing a great job since the beginning, and this is what we're saying, when you're thinking about what kind of innovations you're going to bring out, consider the affordability factor, talk to those target ministries of health who would be doing those purchasing, figure out what is actually for them that margin of costing that they could work with, and then think about how you can develop a product. Otherwise, in these contexts, you might have these diagnostics available, as we already know. They exist in many areas, including for TB, and they're just not being used because of cost.
Thanks very much. Now, if you pass the microphone to Manica, I'm going to ask him about the role of public health actors. What is the best role, considering what you've been speaking to us about, and each person who's heard here, the general role of public health actors? What actually can we do? And then I'll take any questions from the floor, and we'll have a microphone ready.
Yeah, I think the most important thing is to bring and reinforce the public health perspective at all levels of the debate, whether it's at an international level to a country level. I think public health actors also have a very important role to educate and advocate. We have to educate ourselves, we have to educate in a broader sense to our peers as well, and we also have a very, very strong role, I think, in advocating. I also think we also have a role in the implementation side as well. I think it's wonderful to really hear what you were talking about, the International Federation of Pharmacists, and the work that you're doing. And I think it's also how we try and build bridges between different types of associations that are going to be important. I think there's clearly also, one very important aspect is the public health agencies at country level. And these can be obviously part of the government structure, they can be outside the government structure, such as professional associations and so on. But I do think that at the end of the day, a lot of responsibility should be coming back at country level, as well as ownership and the leadership as well. I think a big role that public health actors have to play, especially at the government level, is to to prioritize and then provide the resources to do this. One final thing I would say is just to mention, to acknowledge that I think it's very important what was said about diagnostics. In fact, one of the things I didn't mention was when we started working on a project for developing our STI drug, one of the things that came up very early was a diagnostic. And I think one of the things that we are now going to be working on, even in fact next week we'll be having a meeting with WHO and find on this, is to actually think about how we can build in the diagnostic component on top of the drug part. And one thing we can think about is how we can twin the use of new drugs to diagnostics. And they could be, as you say, mentioned, existing diagnostics as well. I do think there's a role to think about how, and this links into the role of what public health actors decide as priorities, to see how we can really effectively scale up the use of important diagnostic tests. Obviously, I think the applicability in the developing country context is, I think, going to be one very, very important aspect to consider in the future. And there again, I think in the debate we talk about from the public health side, recognizing the huge variance that we have in context in different countries, I think actually is going to be one of the challenges we'll see in the future.
Fantastic. I'm just looking to see if anybody would like to make a comment on these. I'm just looking for a hand. And in the meantime, I will comment that one of the roles of the World Federation of Public Health Associations and its member associations has been to develop a call for action on antimicrobial resistance. And already we have over 60 organisations from around the world, either public health associations or partner organisations that we have around the world, and that will be continue to be circulated, and at the end of the day we will be seeking support from the meeting for that, in addition to those collaborators and those associations that have worked with us. Is there a question from the floor? Or a question or a comment? We do have one over here. Thank you. Thanks very much.
Thank you, Katrina from Fine. I fully agree with Manica's comment on the importance of associations and federations, and so my question is mainly to you, Philippe, in that, you know, the use of diagnostics in pharmacies is feasible, right? Could be feasible, and you know, what are the barriers in your, you know, we're moving to self-testing in HIV, for example. We're thinking about it in hepatitis, so pharmacists should well be able to use diagnostics. How could we make that happen? Or pilot at least?
I think it's already happening to a degree. Certainly there are some countries around the world where people are already using strep A tests, sore throats, so they use a clinical scoring system first to sort of try and predict the level of a strep A throat infection and then treat it. I'm certainly published on that, and we've shown that out of the number of patients who present with a high score, we're actually finally giving antibiotics to less than 10% of them. And that's actually quite sort of good. And I've just reviewed a paper for France, an area in France, we're doing sort of just the same. One of the bits we're exploring in England at the moment are direct referrals from our telephone triage system in the NHS. We'll have referrals directly to community pharmacies because they're open for longer hours and they can see people with a viewing of doing CRP testing and sort of things like that. And we are exploring things like procalcitonin point of care testing as well in COPD. So I think there's an awful lot out there. We've seen chlamydia testing for a period of time. And I do think one of the elements that we have to do is work in partnership with all of these elements. I think the biggest stumbling blocks in all of this is we talk about the cost of antibiotics, the cost of a diagnostic test. We don't talk about the value of an antibiotic, because when we lose an antibiotic, the actual overall cost to society is enormous. There is a southern European country that has just been reviewed in the last couple of years by ECDC that has said resistance is almost at such a level you really ought to consider whether it's safe to do transplantation. You can go and look them up on the ECD's website when to the country. To me, try putting a value on that, having lost your carbapenems and that type of thing. And so I think we have to take a total different way of looking at it and use some of the economists to work the value out. I work with NICE and York University. We've just come up with our first draft of the value of an antibiotic de-linkage model, and that will be coming out very soon. And so once we've got that value, we might be able to have a bit more of a discussion on the diagnostics and the antibiotics and how it fits in, and then developing potential models for getting the community pharmacist as the first point of care to try and do some of these. But, and this is a big but, beware of trying to get the general public to think there's a test for everything. Because what it will do is it will drive the public to say, I want to see what the computer tells me is wrong with me, rather than actually either self-limiting infection. So there's that big word of caution in there.
As you pass to Gary, there's a neat phrase I came across not so long ago, remembering that when it comes to sickness we spend, when it comes to health we invest. It's a really interesting framing of the sort of work that you're talking about. Gary, you'd like to add something?
So I want to come back to the question of access in low-income and perhaps low- and middle-income countries, because I think it's really important that we have to get beyond the obvious there. Because it's obvious that cost has to be low in order to create access. We have to get beyond the what and talk about how do you actually create access. And we've had a lot of experience doing this, and I'll use again HIV as an example because it also required laboratory scale-up. So at the time antiretroviral access was scaling up, there was an underappreciation again for the need for diagnostics, a CD4 test to measure immune system depletion, also the viral load test. And the Clinton Health Access Initiative, I have to give a lot of credit to them, they understood early on that to get to the how, you needed to establish access agreements that also had commitments around the products actually going into use. So we ended up entering into an agreement with the Clinton Foundation to drop the cost of the CD4 test by 75%, down to a very low cost, in return for having commitments about the volume. But even that wasn't enough. There were very few labs that understood how to do these tests properly. We trained laboratorians in 60 developing and emerging countries at the time. Then we went beyond that and worked with PEPFAR because there were not enough labs that were at an accredited status in 6 countries to work to do basic quality control training for laboratories to move them up towards accreditations. Then we noticed that the way that samples were being drawn and transferred was invalidating sample results and creating risk. So then we did in 8 countries phlebotomy training, extensive, including opening up schools of phlebotomy. So the commitment was very strong. But that had to be anticipated, all those steps. The same process has to happen here. We have to figure out how do we get those laboratories up to the standard so they can do something like identification and antibiotic susceptibility testing. Very, very important here.
Yeah, and if Viviana would like to make a comment, I'm still keeping my eye open, and I know that there's a question here. If you can have the microphone, stuff here.
Quick comment on value issues. So clearly, fully agree that the value of losing antibiotics or those health technologies that we have available is critical. In particular, we're looking at it as global public goods, right? That this is really a benefit that we have to concern for everyone. What we do have concerns about is with value-based pricing, which is different. One is to recognize the value and why we need to conserve, so why we need the multitude of interventions we're talking about today, including, as you mentioned, the key issue of preventing infection in the first place. That's where a lot of countries really need to focus a lot of their attention, versus in others, misuse and overuse has to be critical interventions. So, of course, the value of doing all these interventions is precisely to conserve what we have existing. But value-based pricing creates this a very, very big concern for us about trying to put, let's say, it would really become for the end user, for the patients and the people in need, and for government budgets, a very big strain if we're saying that, well, if we're evaluating economically the conservation side enormously, then what does that mean in terms of the final payments for governments already very strained budgets, as well as for populations that pay out of pocket? So that's why we are very much concerned with taking value to value-based pricing.
Thanks. Thank you very much. I'll move to the questions from the floor. Would you mind introducing yourself?
Yes, my name is Nana Yosin. I work with the Food and Drugs Authority. On the question of how we can get pharmacists to to support the use of diagnostic testing, I want to say that in Ghana there's been a collaboration in the area of malaria control between the Pharmaceutical Society and then the National Malaria Control Program, where pharmacists have been trained, because as Howard said, they are the first point of call when people are sick, and pharmacists have been trained and they receive diagnostic tests through the public health system so that they can also offer tests to patients, and it's working very well, and they can report through the public health system the number of tests that have been done, the number of tests that are positive, and the number of anti-malarials that have been dispensed. On the other area of diagnostics being affordable, I think that it's not only affordable, we need simple technology when it comes to diagnostic testing, because in low and middle income countries, we do not have enough trained doctors and pharmacists, and therefore, with the new WHO tax shifting, we are moving to sub-professionals, nurses, paramedics doing these tests, and these tests must be simple enough. And the test should not just come, it should be accompanied by training, because they cannot do the test without good training. So that's my contribution.
What a great contribution. Did anybody in the panel would like to comment on that or build on what's said? It's really interesting, we've listened from pharmacists, we've listened about nurses, you've mentioned paramedics, and so there's a whole range, apart from the medical practice, there's a whole range of other health professionals, physiotherapists and so on. These are people you must work with, Philip. I wonder if you've thought about, or anybody, maybe Peter from World Health Organization, if you thought about how we engage those other health professionals.
I think I would refer that question to Mark, because he's our overall AMR director, if I may. Mark, do you want to?
Yeah. So Peter's flicked the question across to Mark, as I'm being too difficult to handle. That's all right. It's an appropriate one. Mark.
It's an easy one if you have one.
No, but I think we tried indeed to broaden, the whole scope of people who are involved in AMR. And there's one group that has not mentioned till now, that's the dentists. And again, I don't want, to praise always UK, but UK again has developed an excellent campaign to reduce the use of antimicrobials in dentist practice. So this is just another example.
Yeah. It's an interesting example that you choose, because of course oral health is something that in most countries I think is given a too low a priority, and yet has so much impact in so many other ways, and particularly around antibiotics. Philip, please.
Thanks for that plug for the dentists.
Yeah.
Wendy, we over the moon, you've mentioned. I think for me, where we seem to fail at the moment is we haven't made antimicrobial resistance everybody's problem. I think the problem we've got is nobody understands what antimicrobial resistance is. And if I could change one thing, I would get people to start focusing on infection. And that's what we should be talking about, infection. We should talk about preventing infection, optimum treatment of infection, so those with sepsis will treat promptly, and then de-escalate as soon as we get appropriate sort of things back on there, through stewardship, and then if we have outbreaks, we have control on there. And I think if we could get rid of this whole thing of antimicrobial resistance, and I know we never will, and actually focus just on infection, because the public understand the word infection. They don't understand the word antimicrobial resistance. And then between the various organisations out there, come up with tools to impart knowledge. So one of the other hats I wear is I'm the president of the British Society of Antimicrobial Chemotherapy. We provide e-learning platforms for courses on stewardship in multiple languages across the world. We need to almost start working together and find the best way of imparting that knowledge and behavioural change strategies to all healthcare professionals. And so I think that's really key, and I think that's what we have to work together, because that is the major public health message.
I'm sure that message has just been tweeted widely from this room, because those of us who monitor Twitter and in that space, and this is a way of getting our message out very broadly as well, the communications that you're talking about. Here I'm going to get you just to be very brief, because I do have a question from the floor, but you can be very brief in response.
Oh, okay. I just want to second Philip's comment. Like Mark said, there are parallels with climate change. Climate change, no one felt they can do anything about it. It's such a big problem beyond them. When the opposite has to happen, the same has to happen here. Everyone has to feel they can do something about it. Every type of clinician, patients, parents, all need to play a role, and we need to raise that awareness.
Infection, antimicrobial resistance is everybody's business. I'm going to take the question from here, then I'll take your question, but that will have to be it, and we'll get a very brief response. Could you introduce yourself, please?
So yes, I would like to add another group. We have pharmacists here, we have mentioned the dentists, we have the doctors, and I am representing the International Veterinary Students Association. I very much appreciate that we have talked about diagnostics here, and I'd like to also mention that diagnostics, and especially the cost side of diagnostics, isn't only important in low-income countries, but also if we talk, for example, about livestock, because there is a high pressure of costs, and farmers might not want to invest so much into diagnostics, but the amount of antibiotics who will be used in treating a whole flock are huge, so I think that is a very, very important point. And then also talking about incentives of maybe not using antibiotics, vets still earn money by selling the antibiotics, so it's actually a big part of their income, so we might also have to think about that.
Yeah, I think that's right, and I'm going to take this one, very quickly, the one last comment from over here, and while the microphone's going there, and I think later in our groups we will be discussing that issue of veterinary and antibiotics, and those of us who work in public health and think in One Health terms, and I think let's go broader, I think in planetary health terms, these things are so complex and so interrelated. I think, as Mark mentioned in the introductory comments, we're running out of time.
I guess I'm a medical doctor from the Netherlands as well, infectious disease control. I agree with a lot of things that have been said, and very important things that have been said. I just wanted to reflect briefly on one of the things that Philip said, that we have to focus on infection. But one of the wicked things about AMR and what it makes it so difficult to raise awareness is that often it doesn't cause infection. And a lot of the people who are spreading resistant bacteria are carriers. So I really agree with you, we have to have a focus and to raise awareness, and infections can help raising awareness, but the whole thing is that it's not causing infections all the time. So it's a little twist there.
And that's a very neat nuance. I'm just going to ask you all to thank our panel for a really great contribution today in the normal manner. Standing up, thank you.